All right. Roll call. McElwain here.
White here.
York here.
Bishop here.
Talbot here. Perry here.
All right. I believe we have a quorum. Is that correct?
Yes, sir.
Okay, quorum verified. We have minutes from June 5, 2026. I've reviewed those minutes and I hope each of you have. Are there any additions or deletions? Being no additions or deletions, do I hear a motion to accept?
So moved.
So moved by Dr. White, seconded by Dr. Piszczek. Do I have unanimous consent to approve the minutes?
Yes.
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 Okay. We have the financials now, Dr. White.
Mr. President, members of the board, members of the public, in the board packet, you will find the financials for the July 2026 board meeting. Here are some points about the fiscal year financials with the period covering October 1, 2025 through September 30th, 2026, and the month ending May 2026. The total revenues for the fiscal year are 72.88% of the annual budget. At this point, they are 6.24% higher due to unanticipated increases in the following categories during this timeline. Mobile dental clinic facility, portable dental operation application for certification fees, the ADHP instructor certification course fees, dental hygiene license by credentials, and the ADHP application fees. Also, the operating expense for the fiscal year are 44.77% of the annual budget amounts due to several expense renewals occurring in June and July, causing the percentage to be below the 66.64 mark. Examples of these expenses are Canvas, Respondus, iGov. And noteworthy, the dental annual registration fee and the dental hygiene registration fee are at 94.34% and 93.63% respectively, as expected at this point of the year. This accounts for the natural attrition of those licenses who are retiring, disabled, or not returning to practice. The permits, the CS, OCS, PS, and the GA are all approximately 90%. That concludes my report.
Thank you. Are there any questions on this report from the board? To hear a motion to accept? So moved by Dr. Piszczek, second by Dr. York. I have unanimous consent to accept the finance report?
Yes.
Yes.
Okay. All right. We're down to vaccine answers to questions regarding hepatitis B. Okay. Dr. Landers is the Chief Medical Officer of the Alabama Department of Public Health and deals with the vaccines.
Hey, Dr. This is, I don't say what I'm in the Board of Dental Examiners. I'm being you on speaker and I'll be looking. I'm fine. Thank you so much.
Dr. Landers, Ms.
Yes.
Mark McElwain, how you doing?
Dr. McElwain, is that what you're saying?
Yeah,
Okay, I think we know each other, right?
we sure do. Awful nice of you to get on with us this morning. We've had several questions about vaccines and hepatitis B vaccines, and we were just wanting to clarify some things with you.
I'm sorry.
We were just wanting to clarify some things with you. I'm sorry, I didn't have my speaker on.
Sorry, I lost you there for just a minute. Okay, well, I'll certainly see what I can do. How would you all like to proceed on this?
Dr. McElwain, I'd actually sent some questions to Dr. Landers, and I had a conversation with Gina, and I had a conversation with her last week. So that kind of tees up what we're looking for from the
Okay.
program. Dr. Landers, do you have that list of questions?
I actually do, but I will have to reach over and get them. But if you have them and would like to ask them, that would be just as well.
Okay.
I may have told you I broke my hip a few months ago, and so I'm not moving like Jagger.
No, there's no problem. All right, so I can go through the questions. So the first one was if an individual completes a 3-dose series in 30 days. So that means they've taken all 3 doses or 30 days or less, followed by a titer with a positive result 2 to 4 weeks later. Is that protocol acceptable? If not, what is the recommendation for these individuals? And we do have examples of what we're bringing up today, the students that are doing these things.
Of course, my answer to that would be it depends on the product. There is one product that is not used a lot for this sort of thing, but has been used. It's a product called Twinrix, which is actually a hepatitis A and a hepatitis B product, which can be used in a 0, 7, 21, or 30. But it also, the person also has to have a dose at 1 year. However, if they had a positive titer a month after receiving Twinrix, then that could be acceptable. Now, my problem is that, as I mentioned to you, I think that I really consider most of these situations that you all have dealt with vaccine errors where the vaccine has not been given correctly. And you can't just say, use an off-label, well, I'll just do it, see if you get a response. So if Twinrix were used, that product only, and again, it's not very common. A lot of people actually don't even know the protocol. It can be considered a complete series, and if the person has a positive titer a month or 2 after completing the 3-dose series on time, it has to be 0, 7, and either 21 or 30. It cannot be deviated from that schedule. And they still have to have a dose at a year. The first one to be considered to have a complete series. If it's other products, then that is not considered a complete series. Now, if they have a positive titer, if somebody's used Edgerix or, Recomvax, something like that, if they have a positive titer, that means they've had some response. But basically, you'd have to look at it on an individual basis and say, okay, the minimum intervals of those vaccines, the minimum interval is at least 4 weeks after the first dose, and an overall minimum interval of 16 weeks after the first dose, which is still, it's not absolutely optimal, but it is acceptable.
Okay, we've had some examples where people are submitting titers after 2 doses and they're positive titers. I think we may have talked about that. Is that something that maybe we should accept the positive titer but require them to continue the series and complete it?
Yes, and actually, I have some references from IAC, which is a group I used to work with a lot, I still work with a little bit, but I'm in a different role now. As far as accepting a positive titer from the standpoint of seeing that they did have some response to the vaccine, while you can't accept the positive titer, they still need to complete a proper series. And by that, I mean, they need to stay with the original product if they possibly can. Now, some people will say in a situation where you don't know what product has been given, that you can switch between the Edgerix or Recomvax. I have done it if I had to, and I didn't have any other products available. But the main thing you have to look at there is even if you are switching between products, you still need to give a proper series. And the reason being, and I know all of our healthcare providers here understand that if we don't give a proper series, that we've not given the vaccine according to how it's been studied. Off label, it may work, but if we don't have data to support that. So while the titer can be accepted as a level of immunity as long as it's 10 international units, and don't just accept a positive or a negative, but if the titer is in the appropriate range, then I would say, okay, I'll accept it, but you must get the proper third dose at the time of the minimum interval for that.
Okay, perfect. One of the things that we discussed was we've got some people on the 3-dose series. They're not going to meet the date and time, although we have asked them multiple times to use the 2-dose series. It has been recommended to let those students know to get with their doctor and move to a 2-dose series. We have not been given that advice. All we've said is talk to your doctor about it. We're not medical people. We're not going to give that kind of advice. Are you recommending that they do or do not move from a 3-dose series to a 2-dose series based on what you just said?
Preference for product. Okay, so from that standpoint, if they have started a 3-dose series, basically they're going to be starting over if they use a 2-dose series. In other words, you can't count. Now, I said you can switch around between the 3-dose series, but you can't count the 3-dose series or part of the 3-dose series and part of the 2-dose series. In other words, you really can't switch over. Now, then you may find a few experts that disagree, but IOC does not agree with that. So if you're going to have to go to a 2-dose series, then you're going to basically be starting over because your 3-dose series is not counting. It's like, okay, I'm not interchanging a 3-dose series product. I'm starting over with a 2-dose series product.
Okay, understood. Next question. We had an example, we may have had 2 examples where they're submitting the first dose and they took it 4 years ago, for example. So they submitted that as proof of their first vaccine 4 years ago. They've got their second vaccine during this process. Should that first dose be counted or should they be starting over with their series as of now?
Okay, well, the good news is you can, whenever they took the first dose and whenever they took the second dose, while it's not optimal, it's not a correct series, if they took a first dose, they can count the first dose and then at that point take a second dose and a third dose according to the minimum interval. Now, those are situations where I actually have seen people be non-responders, so we wind up having to give 4 doses or 5 doses anyway. But if they ever had a single dose that counts as a dose, and you just pick up where they left off. It's not optimal, but that first dose can be counted. Even that second dose, if they have a 3-dose series, and again, I consider most of these vaccine errors, but if they had a first dose and then they had a second dose, and none of them were at appropriate intervals, I still will go ahead and give a third dose at that point, and then I will check titers at about really 1 to 2 months. If these are younger, otherwise healthy people, you're more likely to have them responding about a month or so. I deal with people sometimes that have diabetes or underlying suppressive conditions, or they're older and they are maybe on dialysis, and any of those people are less likely, as they are with any vaccine, to respond.
Gotcha. Okay, last question I have at least. Can you talk to us about a booster? This is the first we had heard that there's such thing as a booster. So we started getting applications in, well, not applications, we started getting responses in that were basically saying they had a booster and then they took a titer. Can you talk to us about a booster?
Okay, does that mean, are even situations where they had 3 doses already somewhere in their life as a child or something like that. Then they got a booster would really just be another dose and then a titer. And as I talked to you earlier, and I went back and reviewed some literature, this was actually a person that I used to work a lot with on these particular issues. These situations where people are, just going ahead and going in and getting another dose. There's not still extremely clear recommendations for quote boosters, unquote, although people will, when they go into the healthcare profession, they check titers and they may be negative, and they'll go ahead and give it. But some information that you can find in some of the references will say, if you're unsure about, if they've had a series, they must have had a series. In other words, they must have had this 2-dose product, they must have had 2 doses, this 3-dose product, they must have had 3 doses. The quote booster unquote would actually now be either a 3rd or a 4th dose, depending on what they had originally. But you have to have documentation that they had a proper series. So when these people go in and have, it's another dose. It's not even any change in formulation, and it could be with a different product. But and then they have a positive titer. Again, if it's greater than 10 international units. In other words, we know they had 3 doses. Now, at some point, they had a 4th dose, and then they had a titer that was greater than 10 international units. I will accept that. But what I don't accept is someone saying, I had a booster, but they can't tell me when they had the first 3 doses.
Understood. Okay, thank you. Those are the questions we had, Dr. McElwain. We do probably need to talk about, and I don't know if we need to do it in here, but we need to talk about if we have a student that has had 2 doses of a 3-dose, it's not time for their 3rd dose yet. They're not going to meet the timeline. Should we suggest that they get a titer, see if it's positive, accept them in the program, and then require them to finish the series? That would be a question that we would need to discuss.
Dr. Landers, this is Mark McElwain. The reason that we need a positive titer is because we do clinical work at UAB, and they require it. And my question is if somebody has a positive titer, then are we safe to allow them to work? And in knowing that we need to require them to finish the series correctly, but does the positive titer give us the ability to allow them to proceed in the program and do clinical work?
Yes, if they have a positive titer, but again, I go back to, I sort of sound like a broken record, and I'm saying it's just for documentation. They need a proper series. So,
Yes, ma'am.
positive titer and it's 10 international units or higher, then that is considered protected. And when the vaccine first came out, I think you were like me, you've probably already been in practice a good many years. And I actually helped work on some of these original recommendations. So, really, when you start, we still believe that this vaccine, and as I said the other day when I was talking with Dr. Thomas about this, really the literature still does not say, quote, have to have titers, unquote. I think it's just because of, the type of patients we might be working with. And so in healthcare professions, we've moved in that direction from the infection control standpoint. That being said, just getting back to this, the literature is pretty clear. We've had this vaccine since the early 90s, and I remember it because my youngest child was one of the first kids in Alabama to get it before it was actually required. And then I gave it to my older child, so I'm going by their ages. But just to say that as far as titers, there is data that indicates that we have people that have had vaccine 30 plus years ago like me, actually, longer than that, and you check titers on them, we did it for fun, and they still have positive titers in international units or greater. And so we are confident that this vaccine, even in people that have negative titers, still, they're still probably immune. It's just that their titer is too low for it to be measured, as you know, in a laboratory, but they actually still have immunity. And if they're exposed, they're still going to respond. So again, we're still in a little bit of uncharted water about doing titers, but I think from an infection control standpoint and, not wanting people to contract hepatitis B, I mean, that's part of the reason that we've seen such a decline in the disease over the last 30-something years, is that, we have pretty much universal vaccinated children prior to now. So that may have been a little bit around the world, but my answer is, if you have a positive titer, 10 international units or greater, I'm going to consider you immune. That being said, I'm going to consider you immune at that moment. That being said, I still want you to have a complete series. Given an appropriate minimum intervals, that's a big thing of mine. Now, if you give it, and I go back to that first scenario, like if I took injuries and I gave it on day 0, day 7, and day 21 or day 30, I don't really consider that to be a proper series. And so I would count the first dose, and then if they hit on day 30, I'd let that be my second dose, because 4 weeks is really a minimum interval, and that person would still have to have a third dose at a minimum of 16 weeks. I mean 6 months was the usual from the first dose, but I can't accept 16 weeks from the second dose in some of the literature, if that makes sense.
Yes, ma'am.
Thank you, Dr. Landers. We appreciate your time.
Sure. And one final thing I would just mention, and I know you're struggling mightily with this, and I told Dr. Thomas, this happens to be one of the subjects I really like to talk about, so y'all just cut me off. But at the end of the day, people need to follow the proper administration. And any deviation from the protocols that is accepted is considered a vaccine error. And so that has to be corrected. And there may be situations where, that's not something you all can sort out, and you need to talk with someone who has expertise in this. I'm fortunate that we did have 2 other physicians besides myself at ABPH, Dr. Bernstein Taylor and Dr. Wes Stubblefield, and they both possess vaccine expertise. And, sometimes in clinical settings, as we all know, that, I'm not an oral surgeon, therefore I don't expect anyone to be, I'm not going to be giving advice on your specialty. But my other 2 physicians, Dr. Taylor and Dr. Stubblefield, that are in my communicable disease branch, can help with vaccine errors, and that's what I consider some of these deviations to be. We want the students to be vaccinated properly, and we also understand that I had kids too at one time that kids just aren't always going to follow what they've been told, and many of these people are young, and so we have to sort it out, but we have to do it according to the guidelines and according to the standards that really afford them the best opportunity for protection and the best protection for our patients. So, please feel free to email me or call me if you need those persons, emails and phone calls. Dr. Thomas, if you'll just send me an email, I can provide their contact information.
Thank you, Dr. Landers. We appreciate it.
Absolutely. Thank you so
Have
much.
a good day.
Okay, bye-bye.
Bye.
All right. I mean, I took from that if they have a positive titer, they're okay, but they must complete the series.
Yeah.
Is that everybody hear the same thing? Okay.
That's helpful.
Yeah. Well, this has been interesting because I think that there's a lot of people out there that really don't understand and I'm talking about physicians like myself that don't understand that you've got a protocol that you stick with, that's the way this was studied and the way it works. Okay. Dr. Swackard, concerns about hepatitis B guidelines and importance of input from dentist population?
Thank you. Appreciated the words that Dr. Levis shared.
By the way, it is 10 million international units on the titer that you want to hit. And if they're positive, we wrote the proposal, they're in. And yeah, they should finish the series. If anyone's a little worried about being accommodating, bear in mind that we are letting in because the federal law states we must, because evidence shows there's no risk. If someone is chronic hepatitis B infected, they can be a medical doctor, dentist, student. It's been litigated in 2013, and settlements were paid. And so if they're considered of no threat to the community, certainly someone who's non-responder or in the middle of a vaccine, they are a no threat, clearly. I'm positive next time there's a CDC guideline update, there was one in 2012, before that to 1991. There'll be one in the 2030s they update, and they'll clear it up very clearly. Or it will be adjudicated where someone says you're arbitrarily discriminated against, I guess it'd be because of a hepatitis B vaccine response, and you should let me in. Once that happens, this will all be very clear. But now there's gray areas, and I hope we are accommodating getting these students in. 8 weeks completes a series. Hepatitis have B 1 dose, 4 weeks dose, 4 weeks later, titer. And if they fail, they do it again, and then they're either positive and they in, or they're non-responders and they're in. So let's let them in and let them straighten up that paperwork and such as that. And that's about all I have to say there. And I appreciate the advances that the Board of 2026 has done this year so far. I feel a little bad about there's a delay in our hygiene students being able to go to the clinicals, which finding the clinical, to be clear, that's a half day at UAB, is that correct?
No, sir, it's a full day.
Full day, is it?
It's 2 days now to
But it's-
have a
Such a large.
federal close. Yes.
One, thank you, Gina. So, yeah, they, as I understand it, with the advanced, modernized protocol on coronal polishing, I believe you could have your hygiene student doing coronal polishing right now. And if anyone's anxious to and worried about the delay till September for clinicals to get a temporary hygiene license, if they coordinate with your hygienist, they should be able to take the x-rays, do the initial treatment planning, do coronal polishing, have the hygienist come in and do any and all the sub-G work. Double check it.
I do want to clear that up. I think once they're considered a student, they're a student. I don't think they can do anything under that permit without, we might want to look at that. I don't think that they qualify as an assistant anymore. I could be wrong on that, but I think they go into a student model. Same as when they finish the program and they give their permit back up, they're not an assistant anymore, they're still a student. So we probably want to check on that a little better, please.
I would like to check on, I believe they haven't lost their assistant status, I don't think. I don't think they lose the legal rights of an assistant, especially with the advanced training they're getting. So I was hoping they would have full rights to do coronal polishing as our assistants can now. And that would be accommodating, and I hope we do that. The sooner they get their chairside experience going legally, which is legal to do coronal polishing, and then the hygienist double checks it, and then a dentist comes and double checks it. I think the public would be safe, but please clarify that later. Fine, Kelly. I'd like to know that. And good. And that's about all I had to say about it. If there's any particular questions about, I think we heard that they're Tyler positive, they're in, they got straight clean up their paperwork, and that's fine. Should take no more than 8 weeks. By the way, later on in life, I bet if y'all did a titer test now, you would have some of us older people 0 titer. Doesn't mean you're not immune. Your memory cells will kick in immediately as improving. There hasn't been any transmission of hepatitis B in a dental office or medical office in 38 years around the world. And the big thing there really isn't so much vaccine, as I understand it from my studies, it's that standard precautions. That's what dropped hepatitis right off the cliff on cases transmitted. It's standard precautions. We all have to make sure our students are using that. And then the herd immunity we developed over there, overall, it's just not a risk. A far greater, disproportionate punishment to a student or consequence to a student to be kept out of a program because of anything associated with hepatitis B. It's not being transmitted, and it's driving to the school is riskier than the hepatitis. Any particular questions on hepatitis that anyone would think of? Well, I appreciate the time.
Thank you.
Just for a second to clear up something, and someone can correct me if I'm wrong. Here in the ADHD program, you have your, temporary license. When you're in the ADHD program and you have your temporary license, you can assist all you want. You're always assisting. My front desk person comes and assists me all the time and everybody. So you never don't assist when you no longer have that temporary permit, i.e. you're waiting for the final. You no longer can do hygiene during that time. That's my experience based on the 7 or 8 that I've sent through during the year. So, and while you have your temporary hygiene license, it's unlikely you're seeing 8 to 10 patients a day. So you're probably assisting some and doing hygiene some, like everybody in the office gets pulled. I just didn't want there to be confusion, like you can't assist if you're doing hygiene or vice versa. So they can do whatever they want.
I wasn't necessarily talking about assisting. I was talking about doing polishing and things like that without your sponsoring dentist. But again, we'll look into that.
All righty. Just to put this on the floor, I mean, maybe I was super duper old school, but if you came to work for me, and I'm talking about, if you came to work for me, and that's from 1982 on, and I'm talking about the receptionist to the janitor, I vaccinated everybody. All my people were vaccinated because I thought you were just as likely to get in trouble with the trash as you were with a chart that I'd put my bloody glove on. And that was back when there were charts and not computers. And I'm going to say this from Mark McElwain. I still think it's best practice for everybody in the dental office to be vaccinated for hepatitis B, from the lab person to the janitor, to the receptionist, to the bookkeeper, to the assistant and the hygienist and the dentist. That's why it's worked, Grady, is because we pushed it and pushed it and pushed it. And I come from that period of time where it was not an uncommon problem to pop up. And when you get into the poor areas of Alabama, it was a lot more common. So I still think that universal precautions and universal vaccination are good things.
Yes.
Okay. Let's move down to item 8. Dr. Amanda Thompson is going to talk to us about social media postings.
Good morning. Thank y'all for allowing me to come and speak today. I would like to share my experience with my consent order process and some unintended consequences that followed that I believe deserve consideration. Initially, I was reluctant to sign the consent order because I wanted the board to hear my side of the case, but at the end of the day, I really didn't want to come down to the dental board. Ironically, here I stand. I agreed to the consent order ultimately. I was advised that it was the simplest resolution. I was told it was an agreement between myself and the dental board, not an admission of guilt, that accepting the consent order would avoid the expense, uncertainty, and emotional toll of a formal hearing. The person that filed the complaint in my case was not the patient, it was the patient's spouse. Shortly after the complaint was submitted, an extensive social media campaign against me began. Negative posts across numerous Facebook groups throughout the Birmingham area, along with one-star reviews on Google, Yelp, Healthgrades, and any other online platforms. Many of these posts contained inaccurate descriptions of treatment provided and incorrect financial information. These posts were made by the patient's spouse, not the patient. Because of my ethical obligations under HIPAA, I could not respond publicly to any of these false accusations. I was advised by my attorney to ignore the post, believing they would eventually be buried in time. Instead, they continued for years because the original complaint was filed back in 24, I believe. So right after that's when she started posting about me, and the consent order hadn't even been agreed to at that point. Whenever someone asked for a dentist recommendation in or around the Birmingham area, she would post the negative and inaccurate information over and over again, like she had it copy and paste, same thing. Even unrelated healthcare discussions became opportunities for her to repeat the accusations. After I signed the consent order, the online attacks intensified. The title of the order was repeatedly posted online and presented as proof that I had been found guilty by the dental board. Those familiar with disciplinary process understood that a consent order is a negotiated resolution and not necessarily an admission of wrongdoing. Unfortunately, the general public does not. To many people, a consent order appears that finding of guilt regardless of its legal meaning. Notable, a portion of the consent order stating that I maintained that I met the applicable standard of care and denied wrongdoing was never included in any of those online posts. Only the portions that supported a misleading narrative were shared. Friends, family members, patients, and even individuals who did not know me personally attempted to provide balance by sharing positive experience or correcting information. Many of those comments were deleted, and in some instances, the individuals posting them were blocked from further participation. One particularly large Facebook group with nearly 50,000 members in the Birmingham area even reposted my private request asking administrators to remove the inaccurate information. That request was portrayed as an attempt to silence criticism and bully the group from removing the comments. The result was an even greater wave of negative commentary directed towards both me and my practice. I've practiced dentistry for nearly 30 years with previously unblemished record. Throughout my career, I've always treated my patients as I would have treated my own family. Whenever patients have expressed concerns, I've consistently gone above and beyond to resolve them. I have remade restorations and replaced completed work simply because the patient was unhappy, even when the treatment met acceptable standard of care. That commitment to patient satisfaction has always been one of my core professional values. My purpose today is not to relitigate my case. Rather, I hope the board will consider whether additional guidance, clarification, and education efforts regarding consent orders would benefit both the public and licensees. While disciplinary actions are accurately public records, the widespread misunderstanding that a consent order automatically equates a finding of guilt can create substantial reputational harm that extends well beyond the board's intended disciplinary purpose. I recognize that my experience may be uncommon. However, the impact on my practice, my employees, my professional reputation has been profound. I believe that there should be meaningful discussion about how licensees can be protected from the misuse and mischaracterization of disciplinary documents while maintaining transparency and public accountability. I respectfully request that the board consider an issue clarifying statements in explaining the nature and purpose of a consent order. In my experience, many members of the public and even some professionals mistakenly believe a consent order is equivalent to a formal finding of guilt, when in reality it is a negotiated agreement entered into to resolve a matter without contesting hearing and is not necessarily an admission of wrongdoing. I also respectfully ask that the board consider a characterization of the word negligence within the consent order. I fully understand that a consent order reflects a negotiated resolution. However, the term negligence carries a significant stigma and suggests a degree of disregard or indifference that I do not believe accurately reflects circumstances of a lot of cases, especially in mine. Dentistry is inherently complex, and treatment outcomes are influenced by a number of clinical and biological factors, many of which are beyond the complete control of even the most experienced practitioner. In this case, I devoted substantial time, effort, and professional judgment to my patient's care and remain committed to achieving a successful outcome. Had I been made aware of any concerns regarding the treatment, I would have welcomed the opportunity to evaluate the patient and provide necessary corrective treatment. In fact, I first learned that there was an allegation against me when I received a call from board counsel, not the current board counsel, just FYI. My request is not intended to avoid accountability, rather to ensure that the terminology used accurately reflects the circumstances of the case and does not create an unintended public impression that extends beyond the nature of the negotiated resolution. Ultimately, my goal is raising these concerns is not solely to address my own experience, but to help prevent similar situations from other licensees in the future. No dentist should have their professional reputation permanently damaged because the public misunderstands the legal significance of a consent order. Greater clarity from the board regarding the meaning and purpose of these agreements would benefit both the public and the dental profession.
Thank you.
Thank you.
Yeah.
Do y'all have any questions about kind of what happened, or I'm sure if y'all are on social media, y'all may have seen some of it.
Yeah. So social media is cruel, unkind, unfair, and let's just say that the algorithms of social media promote the worst
Yes.
of humanity. As somebody who was eviscerated, attacked, and skewered myself in a very benign situation that escalated to something that was just as horrible as you can imagine, I feel your pain. I know exactly what you're talking about. Like yours, mine led to not just my attack, but family attack and peripheral family. Because anybody that wanted to defend you and colleagues who I've worked with for 30 years attacked because they said, you don't know what you're talking about. He knows what he's talking about, and anyway, I think that we can talk with our counsel that if we need to place any clarification on our website, on our database, before somebody gets it. We've tried to be very careful how we put the information as required by law. The dental board doesn't operate in a vacuum. We are sanctioned by the legislative and executive branches with certain things, and we are inspected, and they want to know that anything that has to do with discipline, that we have a way that it can be accessed by the public. And so we've tried to pick the most benign way we could, but that's not the truth about anything to do with any disciplinary process, because it's often not perceived as benign at all, when the skewer's sticking through you. I know. I hear your pain.
You want to respond, but you can't respond because of the HIPAA and the fact she's not, in my situation, she's not even patient, one, so this, response, she's not my patient, not the patient, and, there's just so many ifs and ands, so it's better to leave it alone, but then, every week I get another, oh, she's posted again, it's like, so,
Yeah.
I don't know what else,
There's no winning.
yeah.
There's no win.
And even the attorney that represented me in all of this, she said that she has represented tons of people for the dental board. She's never seen anything like this. And I told her that was one of my quotas. I said, this lady is a little, she's not going to stop at this. And that was one of the reasons I kind of wanted to have a hearing, but then I just didn't want to have to deal with it all. And so she said, it'll just go away. And it didn't go away, it intensified. And, and I had even my colleagues, texting and calling me and saying, oh gosh, this is terrible. We all read it, and patients, has it affected my practice overall? I don't think so. I mean, I think at the end of the day, if someone really thinks I'm that terrible of a dentist, I probably don't want to be training. But, it still just hurts you to
I understand.
when you've done everything and you didn't feel like you did anything,
Okay.
But I wanted to just bring it to y'all's attention because, it's a different day and age with social media and it might be something that's about to start coming. So,
Okay. Thank you.
you're welcome.
All right. Let's take a short break and we will be back here at 9. Okay? Let's bring this Board of Dental Examiners, meeting back to order. We're at item 10, unfinished business, A, continuing education rule change. The public comment period has ended. We received comments from Dr. Ashley, Dr. Wilson from the Alabama Dental Society, Dr. Trammell from the University of Alabama Alumni Association, Dr. Jones from the Academy of General Dentistry, Dr. Dobro from the Alabama Dental Association, Ms. Karaki from the Continuing Education at UAB, Dr. Sitz, Dr. Clayton from Huntsville, and Dr. Adams, all making comments on this rule. With those comments, everybody has received them and considered them. Before we consider the rule, are there any further comments? Okay. Do you have the rules where you can read it, please? It's in, okay, I'm sorry, I didn't see it.
It's behind the public comments.
Everything prior to that was red and stricken. That's the new rule.
Okay. What I need is just what the change is. Or do we rewrite the whole thing?
Oh, yeah.
Yeah, but the whole thing was read.
Okay. All right. All right. Well, ask our legal counsel, do we have to read it out? Oh, no, I don't. I was thinking we did. Okay. All right. You have the rule behind you, mandatory continuing education for dentists and dental hygienists. And the most substantial change in it is the fact that we are discontinuing the in-person requirement and allowing any modality of education. Am I correct on that?
Yes.
Yes, sir.
Okay. All right. Is there a motion to accept this rule?
I'll make a motion.
A second? Second by motion by Dr. York, second by Dr. Talbot. Is there discussion?
I do. I'd like to read just a little bit of my thoughts before I cast my vote. I've listened carefully to the comments made by the dentists at the GCDC meeting, as well as emails, communications I've received from professional organizations that support maintaining the current requirement for live in-person continuing education. I respect those opinions and agree that live education provides valuable opportunities for learning and professional interaction. At the same time, I also heard from many dentists who support greater flexibility. Their concern was not about completing fewer continuing education hours or lowering the standards. Rather, they believe the board should not mandate the method by which they obtain approving continuing education. As I considered both perspectives, I kept returning to the same question. What best serves the public while maintaining high educational standards? My support for this rule is not about lowering standards or replacing live education. It's about recognizing that quality education can be delivered through multiple approved modalities. For example, I recently completed a virtual suturing course that was available. It was not available locally, and I wanted to do this for my patients. The instructor mailed me a suturing kit so I could practice the techniques during the course. I had access to the training for an entire year after the course. That allowed me to review and reinforce the material long after the course ended, something that was not possible with the live lecture. Technology has expanded access to nationally recognized experts and specialized education that may not be available in every community. I believe the board's responsibility is to ensure the quality of continuing education, not to require one specific method of delivery. One dentist suggested at the meeting that we past attended to ask my patients. Overwhelmingly, my patients said they trust me. One patient told me, I can't determine how you get your education. I came here, and when I came in the door, I trusted you. I believe that reflects what most patients think about their dentists. They trust us. They trust this board to ensure that the licensees remain competent and current. This rule is not about eliminating live education. Those who prefer in-person learning can continue to attend live courses. It simply gives dentists and dental hygienists the flexibility to choose the approved educational modality that best meet their professional needs while preserving the board's educational standards. For those reasons, I'm sorry it took me so long to get to this, but I really wanted to be very careful in making this decision. But for those reasons, I'm in favor of the proposed rule.
Thank you, Dr. White. All right. Dr. Piszczek.
I'd like to thank everybody for writing the comments. I think they were very enlightening. I started thinking about the rules, and then I started thinking about how this organization, this agency, we had a similar situation a few years back. If you remember COVID, everything was Zoom, and it was interaction, and they passed the courses, but when they do the licensure exams, we had a terrible failure rate. And I started thinking about, okay, we're professionals. We're treating this as a profession, not as a hobby. And I think we're probably making a mistake going to all modalities because of the attention span that we have. We also have, if you remember when we went to the CE broker and we were doing paper, we had like 300 or 400 licensees that they told us they never did CE courses at all. And then when we start renewing the process, we cannot get the phone numbers or the email address because the idea is, oh, my front office or my office manager takes care of that. I wonder how many office managers are going to take care of watching the video and answering the questions for the doctors. Now, having said that, the way I'm going to vote is going to be different. I will abstain from this vote for this reason. I want to make sure everything's transparent. I have a son-in-law that does CE courses, my case, and he gets money from it. I have my son, he's the president of the Bowling County Dental Study Club, and he gets money from it. And I have another son that he does the same thing. So being transparent, I don't want to make sure that I have to abstain because I don't want to have a conflict of interest. But you know how my feelings are. So my vote is to abstain from this for those reasons, being transparent.
Thank you, Dr. Piszczek. 270-X4.04. And I want to make sure everybody understands that this rule applies to the renewal cycle beginning after October 1, 2026. So it's next year that this applies, not this year. All right. I'll call the question.
Dr. Malcolm,
Yes.
may I say this? The Alabama Administrative Procedures Act governs the proposed rules and rulemaking. And under those rules, if the agency receives conflicting views during the comment period, the agency is required to issue a concise statement on the certification of the principal reasons for or against adoption of the rule. And the statement should specify the agency's reasons for overruling any consideration urged against the adoption of the rule. So in this case, because there are comments both for and against, the board does need to issue a statement concerning why they overruled any comments that oppose the rule.
All right. Well, I would think you would do that after you vote.
Yes.
Yes. Well, I think Dr. White's statement was fairly succinct in the reasoning. And I think that the board could reasonably adopt that. Does that sound reasonable?
Yes, sir.
Okay. All right. Then we will adopt Dr. White's statement, and if she'll submit it.
I will.
Is that acceptable?
Yes.
All right. Then I'll call the question. McElwain, yes.
White, yes.
York, yes.
Piszek abstain.
Talbot, yes. Perry, yes.
All right. And so 270-X-4-.04 is adopted. All right. Let's move now to anesthesia inspection team. 270-X-2.24. The public comment period ended on that. Dr. Cosley, would you just summarize this rule for us quickly?
Sure.
Focus our memory on this. This what this will allow is to modify.
Is to modify the criteria for the inspection team to allow us to utilize seasoned, experienced, and well-respected examiners who, because of their stage in clinical practice or lack of clinical practice, were not maintaining a current anesthesia permit at the level of their inspection. They had for a period of years. They remain licensed dentists, but they would no longer necessarily be practicing. So it modified the criteria of the inspection team.
All right. And it allows more flexibility so that these teams can more efficiently get this done and not have people waiting.
Correct.
Okay. Do I hear a motion to accept 270-X-2.24? Dr. Piszczek recommends. Motions. Dr. York seconds. McElwain, yes.
White, yes.
York, yes.
Piszek, yes.
Talbot, yes. Perry, yes.
And 270-X-2.24 is adopted. All right. And administratively, these will be in effect, is it 45 days? I think that's correct, isn't it?
It's 45 days from when it runs. Whenever it's published, we'll have to see when the publishing date is.
Okay.
I mean, I'd probably more likely 60 days, but yeah, as soon as it's published, 45 days from that date.
Okay. All right. Now we're to an anesthesia question. Ordering drugs without a sedation permit.
This is an interesting situation that has come up. So in the past, before this board has taken a look at things with more critical examination, there were some things that we were doing based on what we were calling policy that might not have actually been based on firm legal grounds. And one of those involves ordering drugs without a sedation permit. The board policy in the past was that no dentist in the state of Alabama could order controlled substances in their office that would be used for anesthesia purposes unless they had an anesthesia permit. So there would technically be no reason for Dr. X, who did not have an anesthesia permit, to be ordering fentanyl in the office and storing it in the office, or IV Versed in the office. But legally, if they had a controlled substance permit and a DEA permit, there was actually no law that stops them from ordering it and storing it there. There's no purpose for them to have it. There's no legitimate use factor for having it, but there's no legal rule that allows for that, that allows us to say you can't have it. So with Shannon's help, we contacted the DEA, and that is their position, is that there's no federal statute or DEA statute that says you can't order it and have it and store it. You can't use it. You can't administer it because you don't have a permit, but you could technically have it. Well, you can see what that does. That immediately presents a situation where we have uncontrolled narcotics, controlled substances in a multitude of offices potentially throughout the state. And so because the DEA and the state law doesn't say you can't have it, the board, though, can be more restrictive in their statute to the dentist that now prescribes what you're allowed to do. And so what we're proposing is that the board adopt a rule that says you may not possess in your office Schedule 2 or Schedule 3 or Schedule 4 drugs whose sole purpose is for the use of parenteral sedation, oral conscious sedation, or general anesthesia without having a permit issued by the state board and a permit by the state board for the use of those medications. Again, it sounds like common sense, but right now people could order it and store it. And so that's the rule that we're asking. It's a proposed rule that we'd like to put on for consideration and voting of the board, that no licensed dentist in the state of Alabama may possess under their control any Schedule 2, 3, or 4 controlled substances, DEA controlled substances, without possessing a permit issued by the state board for the administration and use of those scheduled drugs.
Has this been an issue in any offices that you're aware of in Alabama?
Yeah. So what ends up it is. So what's happened is, and I'm going to bring up one other point that then tailors into this, is that we have dentists that have failed the anesthesia evaluation, but their safe has a significant amount of controlled substances, but they failed the permitting process, and they're not going to reapply for the permitting process, or they have to take more education, so they're not going to be applying for it soon. And they have those medications, and they're just sitting in the office. Because they're not in a permitting process or have a permit, we're not showing up at their office to do any kind of inventory checks on a regular basis like we do if you have a permit. We're in every number of years to go through and reevaluate it. So technically they order it, they have it, it's stored. No one knows that we don't know that they're there because they're not in the permitting process. But they possess significant medications that we all know have a high diversion potential in the community, and that's why we want to do this.
If the board entertains this and we make a rule, is this something that would be clearly communicated to that failing dentist that they can no longer be in possession of that? I just don't want to see them get caught in a loophole.
Sure.
Does that make sense?
It does. So what we do, Dr. York, and what has been our policy, but it's been a policy, but it wasn't backed up by any true statute or board rule, is that the state board investigator, once somebody failed, would go and secure those medications. The problem, and they would secure it and then dispose of it properly. The problem is that we were doing that without the legal rule that allowed us to send him in to secure those medications and seize those medications. All right. Before we actually formulate that, I'd like to just bring up one other thing that tailors into this. We are seeing on an increasing number, and when I say this, I mean up to 2 times a month now, where a dentist in the state of Alabama will possess a proper anesthesia permit, general anesthesia, parenteral sedation, oral conscious sedation, They will have the medications in their safe because they possess a current permit. And then for one reason or another, they leave the state of Alabama. They are no longer practicing in the state of Alabama. And they basically turn in their keys to the office. They pick up their final paycheck. They load their family up and they drive to Wisconsin. And all of those medications are left sitting in an office, uncontrolled by anybody. And this is happening now regularly, and it's happening more now that we have more of a corporate mentality where the dentists, even the partnering dentists in the practice, where it used to be if your partner left, it was your practice, so you maintained everything. Now with the corporate mentality, it's like, well, listen, I work 5 days a week in those 3 operatories, and this is what I do. I have no idea what they're doing. Some manager that's sent in is running the practice. And we're finding this regularly. We within the last 30 days, we found 3 offices where the dentist has left and all the medications we go in to inspect another doctor that's coming in. We say, well, where are your controlled substances? Well, these are mine. Well, whose safe is that? Well, that's the doctor that left, and I have no idea. And then the office manager opens up the safe, and it's filled with class 2 and class 3 scheduled drugs. So a proposal, in addition to saying what we just did with the board rule, is that if a dentist in the state of Alabama is no longer practicing anesthesia in the state of Alabama, they must surrender their permit to practice anesthesia. And they just let it lapse. They just leave in the middle of the year, they go somewhere else, and it's just a current permit, and then they don't renew it next year. But because they don't renew it, there's no triggering mechanism to say, wait a minute, they dropped off. Who took possession of all the stuff they had in there? So to make it a board rule that if you have a controlled substance permit and an anesthesia permit, and you are no longer practicing in the state of Alabama, or no longer keeping that active in the state of Alabama, that you must surrender that permit. So it's not, let me change the word, it's not practicing. That if you are no longer in control of your medications and are no longer going to be licensed in that's the wrong word too. If you are no longer controlling your own medications and providing anesthesia, you must surrender that or notify the board. Let's say not even surrender. You must notify the board that you are no longer practicing anesthesia in the state of Alabama. If we do it that way, that will immediately trigger us to go in. We don't need to do anything with licenses or permit. We can let it lapse, but it's your requirement and responsibility to notify the board that you are no longer practicing anesthesia in the state of Alabama, and therefore surrendering your medications to the board or transferring them. Because you can legally transfer them, but you have to then notify the board so we can make sure that's happening. Because again, this has been the corporate situation. We're finding this regularly. I mean, every single year now, when new people come out, they're replacing people that have retired, left in the military, going other places. And every office we're walking into, we're finding old stuff in there.
Okay.
So if the board will consider that and allow it, let me write it up in a more formal, clean way as a board rule for presentation at the next meeting. If we could do that. Would that work with you, Kevin? Okay.
Okay, so Mike, you'll write it, get it to Kevin, and then let our legal people look at it, and then we'll discuss it further.
Next board meeting, sure.
Okay.
All right. And then the last thing I'll just do while I'm standing at the anesthesia committee report, we're still, again, completely on target. We have people who have a temporary permit, but within the timeline, and they're now already on the schedule for their permanent, their full evaluations. We have nobody pending in a permit with a clean application that's not on a schedule within the prescribed timeline to be evaluated. So everything is caught up. Thank you.
Okay. Hey, Mike, before you leave, now we had that other item that we had talked about interim, about itinerant.
Yes.
Doctors and about some requirements.
That was brought up at the last meeting. Yes.
Okay. And I think we kind of reconstructed some of our thoughts about it because I think they left with the prior executive director.
Correct.
Yeah, let me just find that. Hang on one second.
You have that.
Okay, and the main concern was about people that come into the state. It's Shannon Youngblood is at the top of it, right behind anesthesia inspection teams.
Sorry.
Okay.
Kevin, do you have that? Right. Yeah. Here. Okay. Right. Here's the actual wording. Yes. Correct.
Okay.
Do I present that again?
Yeah. I just want to get our people looking at it and working on it, and we've made these thoughts, and the only problem I see is that, and I mentioned this before, is that we want to make sure that we don't get accused of market participation and restraint of trade and all those FTC issues with this, because we're thinking more about protection. So let's just go through these, Mike, real quickly.
So the proposal, so this was a proposal that started many, many months ago, back I think in September. And again, it did kind of get lost with the former executive director, where there were people working on it and then it just got dropped. The proposal was that you must live 90 minutes of ground transportation from your office with the general anesthesia or parenteral sedation is provided. The exception to this would be if the office is staffed by the surgeon or a full-time partner who also holds a general anesthesia or an equivalent or higher level of anesthesia permit at that office at least 2 days a week. The issue is that when people are coming in and traveling from more than 90 minutes away, so they're more than an hour and a half away, who's providing the post-operative care to the patient? Because once that person is done with the surgical care or whatever, or complicated restorative care under anesthesia, and that person that's providing anesthesia ends up leaving the state, if the patient has any kind of problems in 90 minutes, or doesn't have to be the state, but leaves that area, it's very hard to reach them. They don't have access to the medical records. And it becomes an increasing problem when somebody's trying to then reach the treating doctor. So hospitals, just for a basis to this, if I wanted to apply and do surgery at Huntsville Hospital, and I live in Birmingham, Alabama, they're going to tell me, no, you can't apply for medical staff privileges here. If you're licensed in the state, you're certainly qualified, you meet all our medical staff requirements, but you live too far away to be practicing at our facility because you can't render the care that we expect when you live that far away. You're not reachable. You can't come care for patients. You have to live within a certain ground time transportation. The second was for any general anesthesia parenteral sedation permit holder that lives out of state, the practitioner must perform a minimum of 30 general anesthesia or parenteral sedation cases per year in each Alabama office where the permit is registered. The exception to this would be if the permit holder lives out of state but maintains a full-time practice in the state of Alabama as the dentist's primary dental practice. So if you live in right off the Georgia line, but you practice in Auburn, Alabama, and that's your full-time practice, and you're there 4 or 5 days a week, then that would not apply. And the reason for this is what we find, and we found this at one of the last evaluations, was for somebody that comes in and doesn't do enough cases in that state, when you start asking for things in this office versus another office, they can't even find what's been moved since the last time they were there. So the crash cart was in that corner, but somebody decided that corner now had to be the new portable x-ray machine, so it's moved somewhere else. They're not there enough. They're not working with that staff enough. They're just coming in and doing their thing, but the staff has changed, and the people they walk in with, they haven't even done a case with this doctor again, and yet they're continuing to do cases that particular day. These are the quality issues that we see, and these quality issues can translate into handling of the medical emergencies in a way that's safe for the patient. And then this, I think, is also very critical. Any general anesthesia or parenteral sedation permit holder will be required to have a timely ability, and we define that within 1 hour, to see any patient for a post-anesthesia or post-treatment emergency or complication. Emergency coverage would have to be provided by the treating dentist or a covering dentist who possesses an anesthetic permit at or above the level of that same treating dentist and has access to all the dental records for the dentist. I can't tell you the number of anecdotal times or incidents that we get where a patient has anesthesia in an office, develops a post-anesthetic problem. It could just be nausea, vomiting. It could be a rash. It doesn't have, not a life-threatening situation. They go to an emergency room. The emergency room says, well, what medicines were you given? I don't know. I had it done at that office. They call the office, and the office is answered, hi, if you have a dental emergency, call Emergency Dental Services at so-and-so, so-and-so. They can't even, there's no way to reach anybody. There's no way to reach the treating doctor that did it. And so we feel like there has to be emergency coverage by somebody who's covering for that dentist that's doing the anesthesia, and has access then to the records, who can say, yeah, I didn't do it, my partner did it, but let me get on my EMR and I can tell you what the patient received. And then it ties into number 4, and that is any dentist providing general anesthesia, parenteral sedation, or oral conscious sedation must provide to the patient the emergency contact name of the covering dentist and a telephone number that is answered on a full-time basis, 24 hours per day, 7 days a week. So that when you dial that number, you reach a person, an answering service, whatever it may be, that puts you in contact with a treating provider, not just a referral number to call somebody down the street that doesn't even know they're covering for you. We really think that number 3, that anything that provides the 24-hour coverage, 3 and 4 in this, the last 2 that I presented, those are critical to patient safety. Those are basic situations that when you go to any physician in town and have procedure work done, you get a 24-hour a day number. You don't get, or you don't get something. They'll all say, if this is an emergency, dial 911. But you have the ability to reach an office, and the emergency room has the ability to reach that doctor, if nothing else, if that physician. We need to do the same thing for dentistry if we're providing this level of care. The qualification or the quantification of the 30 general anesthesia cases in each office, I think could be up for discussion. That number could be modified, but the flavor of it, that you have to be there on a regular basis. You can't have 15 anesthesia permits in the state and cover 15 offices on a regular enough basis that when you walk into office number 12 for the day to put 7 children to sleep for a procedure, that you even can guarantee that you know the staff, that you know that they haven't renovated the room that we inspected you in, that the oxygen tanks actually were ordered 2 days ago and are there present. And you know human nature, they're not going in and doing a full facility recheck themselves, or that the emergency drugs that were going to expire 3 months ago, before when you were there 3 months ago, they were current, are no longer current today. That's the flavor that we're getting to. It's trying to prevent that. Questions?
Thank you, Mike.
I've got 2 questions, if that's okay, Mr. President.
Yes, sir.
So 2 quick questions, and this may open up more discussion. Number 1, when you said 30 anesthesias in each office, I totally get there's a precedent with the hospital geographically, like you were talking about, comparing you to Huntsville. This 30 number, is there a precedent for that also, or is that kind of just an arbitrary number that, and the second question is, I can be to Gardendale from Arab in 1 hour, but some days Gardendale to here is an hour. I almost feel more comfortable if this was a mileage thing instead of a time thing. And I get why you want a time thing. I totally get it. But that seems pretty arbitrary, if you see what I'm saying, because Sonia could almost be at Evergreen from Mobile if she steps on it in 1 hour. But Gardendale to here some days, like I said, is an hour. So that, I think I feel more comfortable talking about a mileage thing instead of a time thing.
And the reason that the time thing is probably the preferred way is that the precedent for regulation with other medical staffs and stuff is always based on a time. It's a ground transportation time situation. And you're right. I mean, sometimes getting from here to my house in Mountain Brook is 45 minutes because they're working on this road, but other times it's not. But it's kind of a practical, considered routine time situation that would do that. The 30 cases is an arbitrary number, but what we started looking at was, and this backed up previously, and it really got dropped even a few years ago. We had a situation where we had a number of people that were failing. They were finishing. They got their postgraduate dental training at an approved ADA accredited institution. They were doing a number of cases there. The failure rate of their graduates was extremely high. And there was a tremendous amount of discussion as to why. And there were two reasons. One, some of them were not as prepared for medical emergencies as they should have been, just be didactically handled. The second is that when they finished and they were then applying 9 months or a year later, they'd done 2 anesthesia cases with their temporary permit, or 3. So they really didn't have the technique right. And it's very hard to come up with what's the requirement. I mean, in dental school, you had to cut a certain number of posterior crowns. You had to do a certain number of anterior crowns. If you did 1 or 2 less, did that mean you really weren't trained? Probably not, but you had to have some basis. What we're saying is, and it doesn't have to be 30, but we took 30 because we started looking at at this kind of average of what people were doing. And if you're just going to go to an office and do 2 sedations today and then you come back over there 3 months later and doing another 2, that staff isn't used to working with you. They can't handle emergencies. And so you're not getting enough clinical time with your staff to be able to keep that going. So it's more the flavor of it than it is the number that we need to look at. And this was proposed as a board rule back in September. It was decided that it would get worked on. At that point, we hammered this already by board personnel. It got basically pocketed on a desk and left with paperwork. And then it never really kind of came up. And then I actually asked Kevin about 60 days ago, or maybe a little bit longer, hey, where do we stand with this? And Kevin had not been in the room. If you remember, that was when the board was the staff was restricted. So he didn't even know this had ever come up because this was not part of anything that had been given to him to work on. And so this basically kind of like a pocket veto, I guess, just kind of sat on a desk and nothing happened. But it is becoming an increasing problem. And again, one of the things Alabama has done, and we should really pat ourselves on the back. You can't legislate everything, but we've done everything humanly possible and continue to do everything humanly possible to try to keep anesthesia within certain guidelines, keep it safe, and keep the practice as available as we can, but maintain good levels of safety. And this is one more step in doing that. And I really think, I know you're getting tired of every meeting now, we're coming with one more thing and one more thing related to anesthesia. I really think what we talked about earlier today with the medications, we've done the inspection team. If we can tie this in, I think we're I hate to say we're done because then something else will come up, but I think we've really then tightened up everything that just didn't get done over the last number of years because we thought it was taken care of through a different policy or a different way of making it happen.
Thank you, Mike.
So I don't know what you want me to do with part of it. I'll wait for your.
Well, we have to address safety issues, but we have to be conscious that in addressing the safety issues, we have to be very careful about not creating antitrust issues and market participation issues and things like that. And I think that that we know that there are people who come into the state, do anesthesia, and then go back to their jobs out of state. And I think we want to make it as safe as possible. We want the patient to have someone to contact in case of a problem. And, you know, I think we need to, our legal team needs to sit and look very carefully at what we do here, because we don't want to create another FTC problem, knowing that that we're trying to make it safer, but I'm seeing all the things that could happen and derail what we're trying to do. So in my mind, I think we need to start this incrementally. I think we need to, the first rule we need to pass would be one that would require there to be a contact person for emergency 24/7 for this. I think starting right there is a good starting place. I think the second thing is that trying to make sure that that person that's contacted should have access to records and should be somebody that has a like-kind ability, you know, so that you're not asking somebody that doesn't do any anesthesia to judge if an anesthesia complication has happened or not. So I really think, like you said, 3 and 4 are where we should put our focus, and we need to be very careful about 1 and 2 not getting us in trouble. Okay, so go ahead.
My concern, you know, I just want clarification, but, you know, I want to ensure that we're not penalizing the in-state dentist with this 90 minutes of ground transportation. You know, for Huntsville, it could take me 45 minutes just to get to Madison. So, you know, the 90 minutes seems, or could be very restrictive in the situation when we're having issues in rural areas with access to care. So that does concern me of why we would restrict an in-state practicing licensed dentist, you know, in transportation time, if considering that they did have the 24 hours, 7 days a week coverage. You know, I'm just concerned about the restricting our access to care, especially I think pedo, you know, in some of our rural areas where people are coming into those areas.
Sure. So, I get your example and I accept that discussion. The difference is if that is your full-time office. So if you have a full-time office in Madison and you have a full-time office, let's say in Huntsville, then basically, and you live where you have to travel more, a longer distance to your full-time office because it takes that long. Like we had one in Jasper. There were times I could get to Jasper in 65 minutes. There's times that I-22 be blocked up. It could take me 95 minutes. But the average time without congested traffic and stuff, it allows you to cover those offices. If that is a full-time practicing office for you, it's not a part-time office. That's what we were trying to. We're trying to make everybody realize that the dentist who lives in Mobile but covers an office in Huntsville is an impractical situation for being able to handle emergency situations that occur with that patient. So if you have a full-time practice and I realize where the problems come up and Dr. McElwain's right. I mean, we're not trying to restrict the ability to get to these, to practice in these areas. We're trying to do is make it practical so that if you had to get back and take care of a patient, you could get back and take care of a patient in a reasonable period of time, and you're not, well, you're not hours away. And so we defaulted back to what the hospitals do. So again, if you lived in Decatur, but it takes 2 hours to get to Madison, they would not allow you to see patients in Madison. They just wouldn't let you do it because you can't get there. Now, if the average travel time is 65 minutes, but there's always days that there's heavy traffic, it could take you longer. That's not what they consider. They look at what's practical ground time transportation. I mean, I can get from Birmingham to Montgomery some days in 90 minutes, but there's other days I can't. If I applied in Montgomery, they would tell me, no, you can't cover this emergency room or this hospital because their rule is you have to live 60 minutes ground transportation for that. So we added the 90 because 90 minutes, when you start looking at where people are in the state, you can get to lots of places in 90 minutes. But if you live in Mobile, you can't get to Huntsville in 90 minutes. Okay? If you live in Mobile, you can't get to Birmingham in 90 minutes. So that's impractical to consider it.
So is this basically, with out-of-state dentists that are licensed in Alabama, I would assume that most of those would probably be taken out of this equation? Unless they lived there just over the state line or something?
So if you're practicing full-time in the state of Alabama, but you live out of
Mississippi, yeah.
But you live out of state, but Alabama is
2 hours to get to your office.
That's different because you're maintaining an office. That's what number 2 came in, is that number 2. If the permit holder lives out of state but maintains a full-time practice in the state where they're there every single day, they're there with the ability to care for the patient Monday through Thursday or Monday through Friday on a regular basis, they could live out of state. But if you're out of state and you're coming in to the state of Alabama, then you have to show that that's a active practice, not just a practice that you occasionally go to just to work. I mean,
so should it be that if you live, should it be in state and out of state with those same parameters and not just be penalizing, an in-state person that lives over 90 minutes away? Shouldn't that help them too, if I'm trying to understand this? I don't want to penalize the in-state dentist for living 90 minutes away where there's an out-of-state dentist that lives 2 hours away.
No, I don't think you're doing that. So
Okay.
Rule number 1, which again, I would agree with Dr. McWayne, we need to talk with legal counsel more about, would apply to in-state and out-of-state people. Okay. Number 2 would basically say if you live out of state, you have to do a certain number of cases in state to keep your license current. But we carve the exception out in that if you live out of state, but Alabama is your full-time practice, then you don't have to meet any exceptional qualifications. And while I realize that probably does meet with some restricted trade situations that attorneys have to work with, the flavor of that is that if you live in Tampa, Florida, but you come to Alabama to practice and you do it once a month for 10 cases, you can't maintain the quality of care on a once a month basis when you live that far away. You can't possibly do it.
Wouldn't that knock them out of this situation anyway, because they would live 90 minutes away?
So
if you're Florida people will not be able to practice in the state of Alabama.
So unless they maintain a full-time practice here. Right. Unless it's a full-time. If it's a full-time practice, they can. If it's just a traveling practice, they would be living 90 minutes away unless they had somebody in the practice that had the same level of permit and then that could cover for their patient.
My committee, that's why after I read both of these and thought about it, and I worked it in my mind for a while, and I looked back at a lot of communications between the Federal Trade Commission and ourselves and similarly situated organizations. I see some real restraint issues here. So I think that we can basically say that we can probably figure out how to make 3 and 4 work, and 1 and 2 may be very, very difficult. So what I would suggest here is let's let legal look at it and bring it back to us, and let's talk about it again in a month. How is that okay with everybody?
Yeah.
Okay.
Thank you.
All right. Thank you, Mike. I'm gonna get us back on track here. Let's see. Sorry. The board meeting calendar update, Dr. White.
Yes. So I did add, I think, 1 meeting. I made copies for everyone.
Thank you.
Dr. York,
Dr. York, behind you.
would you hand one to Dr. Finn, please?
I actually had it in the back. I thought.
Yeah,
Okay.
you have a copy?
Yeah.
Yeah.
Okay.
Would you hand one to Dr. Finn?
Give it to council.
So the only thing that is added to that is a September meeting for an organization. I believe the other meetings are listed on the one in our packet. And so I would make a motion that we would vote on this calendar.
Sonia, I got a question. On September, what dates are you thinking?
So if you look, there's I think it's an AGD meeting. That's already scheduled. I just wanted to include all of the state organizations and their meetings so that we would know.
We still have a conflict with the National Engineering meeting in July.
We do. And I think we kind of would have a conflict either way because the other weekend is the 4th of July. And I think we talked about that. We wouldn't have a meeting that weekend.
So we would not do the week following the HUD meeting. There's a week in between those 2 meetings.
And that would still give us 4 weeks before the August meeting. That would be the 15th and 16th, something.
Okay. I think, what did I see? I think we talked about that. I can't remember what was the reason why we didn't have that date. But if everybody's in agreement, we can change it to the 15th and the 16th of July.
Now, what are we trying to decide about September?
Well, because our meeting was so late in August, we couldn't find a date that we could all agree on in September. So we just moved it to the end of the month and then we'll meet on October 1st.
We're going to skip September.
Yes.
And meet September, October 1. The October meeting is the changeover meeting, isn't it?
Mm-hmm. Yes. Well, this is for 2027.
Yes, that's what I'm talking about. That's the changeover meeting where you've elected a new board member and a board member leaves and a board member starts.
We'll also have to approve the draft of the budget next year in August instead of September, because we won't have a September meeting
Right.
for this calendar.
Would that present a problem?
It'll just have to be
You
done.
just have to rush.
Yeah.
And the board member vote ends on September 30, right?
And the last time we tried to skip a meeting, we ended up having to call it right. The last time we skipped the
Mhm.
meeting, we had to call a meeting.
Right.
Because there was too much going on in those 3 weeks, so I don't really know about skipping one.
We can always add a meeting, all right?
Looking at the logistics of the September 30, October 1 meeting for next year, the board would have to verify the winner at that time and install them on the same day because they have to be installed prior to October 15th or something like that. And we're not meeting again after that. So there's a couple moving parts right there because if you have 3 candidates, they're all 3 going to have to be here to be so one of them can be installed.
Right. So, calendar for
September, I don't have, well, let me just, can I see yours, John? Because I gave you my copy.
That's what's important.
Right. What about the one I just handed you?
I got it very fast.
Okay. Let's see real quick. Yeah. Okay, so in September, we have our September 9th through 11th. Thank you so much. That's the AGD MO Coast review in Sandestin. So that would be the one that would have a conflict. Other than that,
we could still probably do the 17th and the 18th.
Of September?
16th and 17th of September.
Okay, because Labor Day, I think we realized, right.
So we're proposing, September 16, 17?
Yes, sir. And then for October, we probably need to move that back a little because of the election.
Right.
Yeah, but we've got to have it before the 15th. So
I knew it was some reason why it was.
Can you have it on 14th and 15th of October?
well, but we have to have the person installed. We have to install the person on the 14th.
Right.
That's a Wednesday.
That's a
That's
Thursday.
a Thursday.
Thursday.
That's right.
If we moved it to that.
That might be the best solution.
The 14th and 15th?
The 14th and 15th of October.
Where we install the new elected person on the 14th.
Mm-hmm.
But then we have,
Did you have a question?
then we have to have what? Who's going to read the votes? October 1st, we have to have a
Well, we
quorum. Quorum, okay. Okay.
Yeah, just so that we could read
Okay.
the election results.
John. And you. Okay.
Okay, so the modification has been made where July now reads July 15, 16, and September now reads September 16, 17, and October is October 14, 15.
Right.
We're going to leave the November and December, the November meeting the same, or?
Yeah, I think so.
Yeah.
Okay, in December. All right.
Great.
So does this calendar work for everybody?
Okay.
All right, do I hear a motion that we adopt this calendar? Dr. Piszczek, second by Dr. York. Do I have unanimous consent to adopt this calendar?
Piszczek, yes.
York, yes.
White, yes.
Okay, thank you. McElwain, yes. Yeah. Okay.
Talbot, yes.
Talbot, yes.
Talbot, yes. Perry, yes. All right, we're good. All right. It gets harder and harder to come up with calendars that fits everybody. All right, got to keep that or I'll forget it. All right, now, Ms. Latham, you want to go to ADEX, October 15th through 17th? correct?
Yes, there's the educators portion of that meeting, yes, sir.
Okay.
And ADEX pays her hotel and flight. by the
Okay.
way.
Did I hear,
Well, before we vote, that meeting also has the attorneys roundtable, which I think would be really, really helpful. It also has the investigator section in it that we maybe should consider.
well, why don't we authorize, the attorney and the investigator, as well as Ms. Latham to attend, if it can be worked out. And then that way, that gives some leeway.
I'll make that motion.
Motion made by Dr. York, second by,
I say,
Dr. Perry. Roll call vote, McElwain, yes.
White, yes.
York, yes.
Bishop, yes.
Talbot, yes.
Perry, yes.
All right. That carries. Let's see now. Name change research for Alabama Impaired Professionals Committee.
Craig had mentioned that yesterday, that he was going to take lead on that,
Okay, so that's still pending.
because it's between,
Pharmacy Board and us. Okay, that's right, that's right. We're both involved in it. All right? All right. Ms. Thomas?
Good morning. First, real quick on GCDC, we're all board members, other than Dr. McElwain, myself, went to the GCDC conference. One of the things that we had while we were there was the IC conference, instructor class. There were only 24 attendees there. So one thing I think we're going to consider for next year is maybe not going there for that. In Birmingham, we had over 200 in February. So we had a lot of expense, and I'll be presenting the next board meeting, the expense for the GCDC. We don't have everything in yet, but it was kind of costly. So that may be a decision that we attend that next year or have that next year. ADHP, there are 54 students that have not put, that we do not know the status of their Hep B. Sorry. 17 of those students, we have not received any updates yet. We go to orientation on Wednesday. We will be calling these people out, calling them out as in, we need to talk to the following people, and we're going down one-on-one conversations or group conversations, what we need from them. We have 11 that started the 3-dose and will not be able to complete that deadline based on what Dr. Lander said this morning, maybe getting the titer, seeing if we can get them in, et cetera, and we'll talk about that. 5 will complete the series if they stay on schedule. And 21, there's a host of things going on with 21 of them. All of this we've been calling. Gina's been doing emails. We've been trying to get them to respond to us, and we will have them in front of us on Wednesday. So we'll deal with all that come Wednesday. We've not officially got the notice on the sunset yet, but the message that I received was it was October 29th at 9:15. So we're supposed to be getting an official notice. As soon as I get that, I'll share that with you all. Director of Licensing, Steve retired. We all know about Steve retiring. Ellie has taken over that position. She's doing a great job. She's learning a lot, but she's doing a really good job with what's going on for her today. Gloria is the new administrative coordinator. She will be starting August 1st, and we will be implementing a few new things that's going to help our licensees. For example, if someone sends in an application, if they send in a letter, if they send in any communication, we're going to be acknowledging their submission from now on. So we're not receiving phone calls and they're not asking for a response. Every time our phone rings, we'll be checking email addresses and confirming we get feedback that we did not get your notice on the constant contact, etc. Part of that is maybe we don't have the right email addresses. So we'll be checking that when it starts. We'll be logging and scanning all incoming mail. Today mail comes in, it goes out to wherever it goes, and then it's there. We don't know that did it get taken care of. You know, moving to electronic office will help us in that area. The last thing is that Mary Beth worked with the VA and we got VA approved for any veterans that want to attend the ADHP program. They will be paying for it for them. So that was really good. And I can give you another 20 updates, but I'm not gonna take the time to do that. Questions? You're welcome.
All righty, let's go ahead and let Dr. Bennett give his wellness report.
John Bennett. I'm still John Bennett. Dr. Garver did assure me I was going first today, as usual. Just kidding, it's a joke. Wellness Committee report. We have a lot to talk about. I thought the first part was worth mentioning about our provider that got re-credentialed with Blue Cross again. That is such a big deal, and I really wanted to mention that again. But he is the credential with Blue Cross, and he's already filing claims, the one that we worked so hard on. So the board gets all the credit for that. That's wonderful that we've changed that. So we're anticipating the name change. Dr. Finn's worked on that. This is important, I think. We just had 2 dentists that completed consent orders. And both of these guys were, as all of y'all know, put on probation. It was punitive. Not basic. Now they would have qualified for a deferral program, but they put their 5 years in. Both of them were taken off Blue Cross as preferred providers. They both served their 3 years and then got it back while they're in the consent order. But they're finishing their consent order, and they do value. They're finishing their consent order. They're no longer responsible to us, but they have gone through the whole process. But, I think we should celebrate the fact that somebody shouldn't have to do that again. And these 5 have come off of it. They do appreciate the Wellness Committee, but having been off of Blue Cross providers and then they were added back. But I think that's significant, and we've completed their completion of that. Interesting. I went to this IDAA, the Doctors in AA Convention, and it's a big conglomerate of people in wellness, or state directors for wellness. And I got to meet with Dr. Clater, who's over in North Carolina, and Dr. Kessler. Dr. Kessler is a former president of ADA. He's his last year, and I got to meet with him, and we talked to him extensively about the nonprofit. Dr. Clater set his up in 1997, and he's helped me, and I'm going to see him. And he has a conference in September, and I'm going to that conference. And ironically, Dr. Melody Jones is one of the speakers at this conference. So I'm really excited. Well, I'll be able to give her some support when I'm there too. So I'm excited about that. The meeting I went to, IDAA, was in Chicago. We took 7 participants in our program to this convention. Huge. We had the most of anybody in the United States of people that attended this conference. Very significant. And everybody was talking about all these Alabama boys. That's what we want, I think. And that is a good thing. And Dr. Kessler, while we were in Chicago, gave us a tour of the ADA building. We felt like we were going to the Holy of Holies of dentists. But we got to go in there, and there's a big picture of G.V. Black in there. And I didn't know this, and all of y'all may have known that. G.V. Black was president of the ADA in 1900. So I didn't know that. I knew we did know about G.V. Black, but I didn't know that he was actually president of the ADA, which I thought was interesting fact. But it was a big deal. It was a good trip. There was a lot of conferences about recovery, drug screening, that kind of thing. All of our participants got to see that. The dentist was credentialed, but I've said that twice now. I don't want to say it again because we worked really hard on that. Our committee, we're very active. We got 2 meetings in the next 2 weeks. It's going to be busy for us. We've got several issues that we're going over, and we're getting that taken care of. We're still working on Dr. Finn and I still are working on the webpage. The name change, which we're excited about that. Whatever's decided about that, I'm sure it will be a positive event. And all other dentists are in compliance. I got one other issue that has come up to us. It was presented by one of the Wellness Committee's members, and the idea is, and this is, I don't mean to throw a cog in the wheel, I mean, to cause a problem, but he suggested that maybe the wellness committee, and we're preparing this, we've already got it prepared. It was that we proposed that hygienists are drug screened before they begin school. And we're getting it together so that they are drug screened before they apply for hygiene school, and then maybe even think about afterwards. As our committee member pointed out, you can't work at the express oil change without getting a drug screen. And I think that's a valid point. Your other nurses, I was hoping Dr. Gers was still here. I don't know if they drug screen dentists when they go to dental school, but they ought to before you go into the clinic, I think. And you know that I've threatened to give drug screens to my employees before. I had 2 quit one time because I threatened to do the drug screen. But, you know, I think it's something, this proposal, we're not ready to present it yet, but it's just something to think about in the future that I think that would eliminate a lot of problems. We might have to open up a table at the first hygiene class for everyone to join the wellness committee, all those that tested positive, but I don't know. That's a joke too. But I think that's something that might be considered. But other than that, everybody's in compliance. Wellness committee is doing well. Again, we are so excited. All of our participants are understanding the deferral program and it's working. And we sure appreciate all that y'all have done to give us that ability to help them in this very vital way. Any questions?
Dr. Bennett, remember, what's good for the goose is good for the gander. You can't do anything to the hygienist that you're not willing to equally do to the dentist as a licensee. So we have to consider that in anything we consider.
I've done drug screens for 21 years.
But the deal we'd be talking about.
Oh, yes, I know what you're saying. Yes, that's a good point. And that, I'm not sure that would be something, but maybe, I don't know. We'll work on that, but that's.
Thank you.
Thank you.
In the interest of time, Dr. Piszczek, you want to give your GCDC report?
You guys can read better than you can hear my voice. So are there any questions? I think it was a very good ethics meeting and very good town hall questioning. And I think, to be honest, I was proud of our team. We did what we were supposed to do, and I think they understand the process. And sometimes having these type of meetings with understanding how things are done, what's expected of them, what's ethics. And I thought it was very productive. And afterwards, I think we probably, and I agree with Renee, we probably should have it in a different day because we're only meeting that day. So the attendance wasn't as bad because people were heading home to beat the traffic. But the communication, I think, is essential, especially how we handle the ethics in the board business.
All right. Thank you, Dr. Piszczek. I'm going to give my report and then we'll take a break for a second. This month I've fielded a number of phone calls on a number of subjects. One subject that I've worked on is the sunset. And I've spent some time with a member of the Sunset Committee going over some of the things that I think are important for them to know. And I'll continue to have dialogue with him. That's Representative Bubba Underwood from Tuscumbia. And he's going to make sure that he disseminates the information I give him to other members. Let's see, what else? We've had a lot of phone calls this month about asking if the Board of Dental Examiners could become involved more in continuing education. And, you know, we've discussed this several times, and it's really not in our mandate to be involved in continuing education except for explaining new rules, laws, and things like that. Basically, this person was inquiring about anesthesia updates and what we could do. And I think that, we need to consider maybe having some things available on our site, on our website. Yes, ma'am.
We do have, anybody who calls in and has courses that they want to have added, like Dr. Pruitt has his on there. We have a resources page for that.
Okay.
As a referral kind of thing.
Yeah, and we'll continue to do that. The other thing that was important was that, I've received a ton of questions about board process, about how we do things and what the dates are and everything else, and when you've got to get something done by and all. And one of the big complaints is the people that some societies have late September, early October meetings, and of course you don't get to CE till after the October date. So it can't go on this year, it has to go on next year. And a lot of those people were asking more leeway about it. And I told them that we don't have a lot of flexibility because that's a statute thing. So those have been the major items for this month that people have hit us up. Don, thank you for being here. We're glad to have you on board. Of course, we'll all have a learning process to learn each other and learn all about what we got going on. Let's see. I think that this would be a good time to take a break, and then we'll come back and start a new business. And in your packet is the legislative report from Ingram, Wyndham Gallagher. You have something you want to say?
Mark, what time you want to get back?
Let's get back in 10 minutes. Okay, and get back going. We'll start with new business. Keep us moving. Huh?
Yes.
We're in new business and, we're down to Botox injections by hygienists, and it says Dr. McElwain. Well, the only thing Dr. McElwain is going to tell you is that, and then I'm going to turn it over to Ms. Perry, is that, I had a great difficulty, with medicine over Botox originally and had engaged with the medical board multiple times, kind of keeping it all back door and keeping it quiet and making sure that it didn't get out of hand. And when the medical board would have questions, I talked to the individual dentist back then and all. I'm going to tell you, it was a multi-year effort, multi-year fight to maintain dentistry's ability to use Botox and injectables, and it wasn't easy. And finally, it came down to either we were going to codify it by having some type of board rule that put it protection for the dentist, so that anything the medical board decided would have to come against the dental board. And I think that quietened it down, even though it was a little rocky getting there. It was kind of a hard concept to understand. So I'm going to turn it over to Ms. Perry.
This is a question that I get multiple times a week from hygienists. I think that we do need to talk about it. I'm probably not the best one to talk about it, but I've asked Dr. Robin Pruitt to come and give us some information if he don't mind.
Okay.
Quick background, y'all all know this. Dentists have been doing Botox and dermal fillers in the state of Alabama for 17 years. I've been doing it for like 16 years. So it was always the opinion of the board that y'all can do it anywhere on the head, neck, face, whatever. We had a proper training. Other states have more restrictions. Like I am now injecting with my license in New York, but in New York, when I inject, it has to be related therapeutically to what I'm doing. Doesn't mean it just has to be masseters, but if it's enhancing a restorative case I'm doing, I can do it, but I can't go there and do their crow's feet because that's not part of my smile, right? So there's restrictions on that. There are right now 5 states in the United States that allow dental hygienists to do Botox. The states are Arizona, Colorado, Kansas, Oklahoma, and Utah. They all have different little rules on it, but the basic bottom line, in my opinion, would be that if a dental hygienist is allowed to do facial injectables in the state of Alabama, Botox, botulinum toxin type A and hyaluronic acid dermal fillers, 1, minimum of 3 years active license as a hygienist. Doesn't matter if it's ADHP or not, active license. 2nd, minimum 1 year holding an Alabama facial anesthesia permit. 2, 3, completion of a board-approved didactic and hands-on clinical course. There's great courses. I teach a great course. AAFE teaches great courses. There's great courses everywhere out there, but obviously you got to take a course. Everything has to be done under the direct supervision of an Alabama licensed dentist who themselves, him or her, is also certified in botulinum toxin type A and hyaluronic acid dermal fillers. There would be an issuance of an Alabama Board of Dental Examiners facial injectables permit, like the anesthesia permit. There'd be a fee for that, $1,500 a year or whatever, and it'd be an annual renewal with board oversights. Doing this, the things I just listed, and this is something I've been making notes on my phone for the last probably 3 years, thinking, this is something we probably could get to. I didn't bring it up 2 years ago when I thought the board was going to yank it out for me. I had to protect myself first, and now I'm kind of like, if we could help hygienists out, that'd be great. But these requirements are intended to establish what would be one of the most comprehensive patient safety and regulatory oversight model in the country in consideration of the other 5 states that are doing it, while expanding access to care and professional opportunities for qualified dental hygienists. So expand professional opportunities for hygienists, maintain patient safety, preserve appropriate dentist oversight, and then align Alabama standards with proven regulated models where appropriate. However, this is discussed or gone on down the road, there's going to be ups and downs about it, like with the CE thing, for instance, like it took there being 48 or 49 other states ahead of us for us to say, okay, we'll do this thing now, any modality thing. So I don't look at the 5 states and think, oh, Alabama's just going to jump on this. Maybe they will, maybe they won't. You know, it just depends. So one of the things that I think of is regarding infiltration certification for hygienists, for instance, right? So they go do the infiltration certification. There's 125 slides. So I think it's 125 slides gone over by Dr. Lewis and Dr. Urban Smith, specifically on doing blocks. Every block you can think of. Blocks right now that if I showed you the slides, some of us dentists, I didn't even know these were blocks that could be done in the mouth. In those 125 slides, there's like 15 or 20 that show how to numb all the teeth on the outside of the face. I don't know how to do that. Like I've done it before, it's kind of an accident, but I don't know how you know how to numb somebody here and here, but they teach them that. They also they do give blocks when they're going through the program. I know this because I've had people go through the program. But yet we get out and we call the certificate infiltration, and we limit the hygienist from being able to do inferior alveolar blocks, which is something they could do. Further in that, it's a larger needle in the mouth with structures we can't hardly see. This needle for doing Botox is 5/16 of an inch long. It's a tiny little diabetic needle. It barely goes in the skin. All this is reversible stuff, like everything goes away, or you can reverse it if there's a complication. So do I think with proper training and all the criteria that hygienists should be allowed to do this? Yes. Now, do I think a lot are going to do it? No. Because if you break it down, it's only about 10 to 15% of the dentists in the state of Alabama to do this. Of those, probably not many do it at the same level I do it. I do a lot. Like every single day I'm doing patients. So they're at a certain percentage, right? The person would have to go through a course. That hygienist would have to want to go through a course, and somebody's going to have to pay $3,000 or $4,000 to send them through the course. The dentist is likely not going to pay it unless they see the financial benefit for them. The hygienist is not going to pay it. If they do pay it, they're going to want more money. And if there's a hygienist, when do they have time to go over and do Botox? Because the dentist has to go in, diagnose, treatment plan, do the appropriate oral exam if they're not a patient of record, and then the hygienist, if they're allowed to, could map out, inject the spots, and the dentist comes in and says, yep, it's all good. So do I think it's something that could be looked at? Yeah. I mean, there's nothing wrong with it. Other states have done it. Do I think a lot of people do it? Probably not. I just feel like sometimes I don't know the right word. I feel sometimes we poop on hygienists like they're just not that qualified, like they're nothing but this. And these other states are doing it like we could do it. It'd be a very progressive move for us to do it. Would I allow a hygienist that's in my office if they went through it to do it? One, sitting back here, because she's done 500 hours of CE in Botox and dermal filler, way advanced stuff. I'm in the room with her all the time. I'm like, what do you think here? They said, no, the pool's right over here. You need 2 units here, only 1 here. He guides me. She helps me. And if not for all these friends in front of me, she'd be putting the needle in, but I know that I can't do that. Yeah. And she's never done it, by the way. But I'm saying if I need a Botox right now, and of course I don't, but if I needed Botox right now, I would go to my office and let her shoot me up. That's how much I trust her. But she's had great training in it, So anyway, that's my 2 cents. Ask me anything you want based on what I know.
Are you suggesting that they do filler as well?
I think if we're going to do it, the reason I brought up the anesthesia is it's so weird to me that we have them go through this program. They teach them every block. I'm telling you, the list of blocks, I don't even know some of these blocks. I just don't. It's 125 slides that I counted that they pre have to study. Then they go through it with them when they're teaching them, and then they're tested on it. But then the board says, but you can't do that. It's like you're only good enough to do this. You can't do this. So yes, in my thought process, if we're going to do Botox, they can do Botox and filler, but they have to be trained on filler. Like my course, for instance, 2-day course, didactic 8 hours, injections the next day, 8 hours. The only thing you get to inject on the patient is nasolabial folds, okay, and marionette lines. That's for the filler. It's advanced to do mid-face. It's advanced to do jawline. It's a whole nother course, It's a whole nother course when I'm doing a person's entire upper and lower lip. Like, it takes training to do that, For me to sit down with somebody 10 minutes and do someone's entire lip and make it pretty and do it right, you don't get that in a basic course. So they probably wouldn't do much of it anyway, but they could only do what they're trained at. Yeah, so yes, personally, I'd say they're both included. But if they just have the opportunity to do Botox, I think it's going to make a lot of people happy. But I don't know that they're going to be utilized a lot. I mean, is it going to be hundreds of hygienists do it? I mean, my course is not going to get packed with hygienists taking this class because there ain't no doctors out there fixing to hand me $34.99 to send them through the class. They've got to see some benefit behind it. So anyway, it's just my thoughts, I mean, I just think it's always good for the board to look at opportunities to be progressive and not to overutilize my time. Thank you for asking me. One other quick thing I'll mention that John Bennett brought up, because I'm involved with working with that with him and Mike. The dental students are drug tested when they start school. They're drug tested when they start clinicals. All right. Every nursing program in the state of Alabama and every state, they are drug tested when they start. So I get the good for the goose is good for the gander thing. We're not saying annually dentists and hygienists have to take another drug screen. That'll come up when they get called. When, a patient files a complaint with y'all, and I go to this hygienist for years, and every time I've gone in, she smells like pot. Like something's got to come up then. You got to question it. So we're only talking about when you're applying to start a program, and when y'all say stamp of approval, good to go, put those sharp instruments and scrape all in their mouth. Y'all have no idea. There's so many of these people out there that are smoking dope every single day and walk around with their little Delta pen, and you just have no idea. So I personally think, because every program, Wallace State Dental Assisting Program.
After that too, but you meant dental hygiene for Wallace, Fortis, and Calhoun, they all drug tests and the both sides.
Every one of them for hygiene drug tests. So I don't know. That ADHD, I think it'd be a good thing and might limit the people starting in the program. I don't know, but
Suggest that on admission.
I think it would be part of your thing. You got to do a background check, all the things you got to do, and there'll be a drug screen. And you don't tell them the date. Jessica just started nursing school, and what did they do? They called y'all all in one day?
Orientation day, they did an unannounced drug test salivary for everyone, for all 200 of us.
So they all got there for their orientation. They had no idea. So you don't tell them the day, obviously, but you could say, hey, in this 6-week period, there'll be a drug screen. And then if they somehow slip through it or steal somebody else's urine or don't smoke pot for a week, whatever, okay, great. But then it's done again before y'all put y'all stamp of approval on them to give them that license that tells the citizens of the state of Alabama, we certify they're safe to practice, which is y'all's number one mandate. So anyway, just throwing my thoughts out. Any questions? Yes.
Yeah, what was the 5 states?
Sir?
What were the 5 states?
They are Arizona, Colorado, Kansas,
Utah,
Oklahoma, and Utah. And I'm not saying every one of them is Botox and dermal filler. They have a pathway allowing for dental hygienists under the criteria, much of which I showed there, to be able to do that. And the board's approved it, yeah. So it's not a huge amount. 5 years from now, it'll be 8 or 10 states. Like there's others right now currently talking about it and discussing it and all that kind of stuff,
A little caveat. Yesterday, I knew this was coming up, so I texted Dr. Louis Malmacher and asked him to call me, and he did. And so we had this talk, and we talked about the states. Utah is the most recent one. I think he told me they're the only ones that is Botox only. I think the other ones are Botox and dermal filler. Also, too, this just caveat, Colorado if you work in a medical or dental office under a dentist or physician who is licensed to do Botox or dermal filler, front office, assistant, whatever, you can go and get CE and then be an injector. You don't even have to be a hygienist in Colorado.
Oh, wow. Yeah.
Yeah, kind of.
Yeah, but all of them smoked up there.
Yeah.
Yeah. They don't even know what they're doing.
That's the caveat. Yeah.
Yeah, Utah was the most recent one, you know. And back to the New York thing, like dentists in New York can do Botox and dermal filler. I teach about 3 courses there. You're training, you know, doctors to do it. But as a licensee now in New York, I'm restricted on what I can do. It can't be cosmetic stuff.
Right.
And the funny thing is that some doctors at this office where I'm at, I said, y'all do Botox. You got your posters and your signs. Like, how do you get away with that? And one of the doctors looked at me and said, well, everybody has headaches here in the procerus and the medial and lateral corrugators, and everybody has headaches. I said, so you get them to say they've got headaches here so you can call it therapeutic. And I thought, God, I'm scared to lose my Alabama license. I'm not going to do anything to screw up New York.
One more question. Can you give us any detrimental negatives to a hygienist doing this? Anything?
No, because here's the thing. There's no mortalities that come out of doing this. There's morbidities, right? All right. And I said the right word. I said yeah. So morbidity for Botox. Worst thing. I don't drop it down enough here, and they come back with a little spot brow, and I give them 2 free units right there, and it's gone in 3 days. Morbidity. I'm injecting the masseter. 30 units. I outline it. I know where I'm supposed to inject, and doggone it, I'm a little bit close to the restorative muscle, and I catch it, and they got a little bit of a crooked smile there for a little while. It's only happened to me once on a daughter-in-law. So yeah, there's nothing bad comes out of this. And like I said, I do this, I train, I'm a national injector and trainer and lecturer. But like filler, there's some areas I don't fill. I don't love doing chins. I don't do noses. Like there's just areas that I don't do because I don't inject under the eyes. I'll send them to a dermatologist because I'm not comfortable. I like things that are predictable. I always know if I do it here, I'll get rid of your 11s. If I do it here, I'll get rid of your pros. I don't do cannulas. I can under my training and the board thing because y'all don't have that as a restriction, but I don't do cannulas. I know how to use them, but like I just like predictable. Boom, boom, boom. So is there anything bad that can happen? Now with filler, of course, you can get necrosis that can occur. You know, so there's parameters. But again, I typically only do filler in certain areas, and if you follow protocols, it's going to be okay.
But again, you don't have to do both.
No. No, you can just say they can do Botox, you know, because a lot of the doctors that I train, they get that little bit of training on filler, and they tell me, I just am doing Botox. The filler scares me. Or they come back and do an advanced course, and then they actually get comfortable with it. So if it was Botox only, I think that's fine. Yeah.
All right.
Thank you so much.
Thank you for your time. When I was giving my report, I neglected one thing. In talking to the people who are involved in medical marijuana in the state of Alabama, I found out that medical marijuana prescriptions will not be on the PDMP, and that means that we have a problem in that we have dentists who inappropriately prescribe medications that are not dental therapeutics. And so if the dentist prescribes medical marijuana, we basically wouldn't find out till there was a problem. Unlike other class 2, 3, 4 drugs, we would see that on the PDMP. And I just want to bring it to the board's attention that we might ought to consider some type of prescriptive prohibition against medical marijuana unless the dentist specifically appears before the board and asks for a waiver.
Why is that not on the PDMP?
Because that ain't the way the law got written. Yeah. So yeah, they're dispensing, not a. So we just need to be aware that there's a loophole there that we need to address. And I'm sorry I didn't remember that a while ago. It just hit me. All right. Virtual sponsor certification, Ms. Perry.
Sharon, Dr. Talbot and I, and we've all looked at this. We're working on slides. We're thinking that maybe, if I'm not speaking too quick, they'll do it by module. So they'll do a module, answer the questions, pass that, and go to the next module. In hopes that more people will be able to take the sponsor course. And for the ones that are expiring and they're worried that their hygienist or their student's not going to be able to practice for 2 days before they get to another course, hoping to just get some of that online and mainstream it a little better.
Okay. So we're making progress.
Yes, we are making progress.
All right.
My next thing is just, that's pretty vague. Just want to make sure that Gina knows that whatever she needs from anybody sitting up here over this next year, just ask, because it seems like it's going to be a bigger class and we want her to know that she has our support and we're happy to step in and help where we can. The third thing is we need to talk about who's being allowed into the program. I know there was some big discussion about pediatrics and all that, but it's been brought to our attention that we have some orthodontic assistants that are in this program, and we just need to be able to make sure they are scaling and getting everything that they need, super gingival, x-rays, bite wings, and things like that. And we need to figure out a system of how to check everybody, not just those, but I don't know how orthodontic assistants are getting the 150 patients that they need. It would be same with oral surgery sending them or endo sending them. How are they getting their 150 required with what they need? So I think that needs to be looked at.
It seems like that we probably ought to specify the criteria for patients. The appropriate
I think
150
they do.
patients.
It's very specific.
Yes, sir. We already do that. And all
Give
that
them to us.
information. And then also in the student sponsoring dentist handbook, Dr. Bosman and I devised a clinical guide, just kind of as a guide for dentists to follow, like start out with this type of patient, as your students' clinical skills progress. Let's move to more difficult patients. They should be seeing a minimum of X number of patients this month. And kind of as they matriculate through the program, more intense, more involved, subgingival scaling, root planing, all the things of how the dentist should guide their student clinically, since, they're with them 4 days a week.
Okay.
So we already do, our best to get all that out there.
So with those criteria already published, we're saying that there are people in the program whose dentists don't have them meet those criteria.
No, sir, that's not what I'm saying. What
Okay.
I'm saying is if orthodontists send you back to your general dentist, which most of them do, if they're cleaning their teeth in between, is there subgingival calculus there? That is a requirement. Is it there?
Okay.
How do they document it? Can they take bite wing x-rays unless, everybody that I've spoken to can't unless they are in practice with a pediatric practice. So if they have a pedo practice with ortho built in, then yes. But if you have a freestanding ortho, typically you can't take bite wings. That's not, you don't have a need to. You send them back to your general for that. So how are they taking their x-rays? How are they doing all of that? And it's just,
So what is the mechanism to address this?
we don't have one yet. We need one.
We have to invent one.
We need one. Dr. Piszczek has some ideas if he's willing to share that. I know I've put him on the spot, but
One of the ideas is during the course, and this is between Dr. Bosman and Gina, is to bring radiographs of the patient that they've seen without their name. So it has to be HIPAA compliant to see if they actually seen calculus. Either you can do it before or after. and just pick, say, 5 or 7 and per student during the year. Something like that, because I agree, you don't put ortho brackets on payroll stage 2 or 3.
True.
And I think we're doing disservice to the students going through these type of practices if they go to a general dentist and doing, or periodontist, being a hygienist. I think we need to address, I think we need to talk about that, but one of it is show me the pictures that you have calculus before and show me that you got it out.
So would we need to have the sponsoring dentist sign off on that as well? Because otherwise, how will we, and I agree that's a good idea. How will we confirm that's truly a patient of record that that student hygienist treated?
Oh, yeah,
Okay.
the responsibility is on the sponsored dentist.
True.
Absolutely.
So we would, okay.
Absolutely.
Okay.
Okay.
And that's all I had.
Well, I mean, it seems like to me that we just need to come up with some way that the sponsoring dentist is, is certifying that they've done it. All right.
Well, on that, now, on the Profi sheets, I will say monthly that students submit their sponsoring dentist. There's an attestation at the bottom, and the sponsoring dentist must sign that. And they're attesting that that student hygienist do perform all of the criteria listed on that Profi sheet on that patient of record within their practice. So we are already having them sign off confirming that.
All right. Well, I reckon we need follow-up on the people that are having people come to the hygiene program that are not in general dental situations, and making sure they understand what the requirements are once again. All right. Budget discussion on ADHP costs and fees.
Just real quick, we actually had a meeting with Dr. White yesterday, right over the process of budgeting, just to let you all know the budget process has started. So we're looking at certain items, and we just gave some examples here of things that are going to be up here. Proctor, the staff. But from the insurance perspective, it's going to go up next year, and we'll talk to Kenny about that next week. GCDC costs, we already went over that, but we're scrutinizing what we put in the budget, and like I said, we met with Dr. White, and the process is beginning, just FYI.
Yeah. On the GCDC, maybe the best thing there is to have that something that we only do every so many years, or something like that, or participate in some way at an interval, because we're cost is getting to be a big issue about everything to do with travel and
I think with it going online as well, if we do the one in Birmingham yearly, and then we do them online at their leisure, that would probably handle that.
Yeah, help with costs.
Yes, for sure.
Okay. ADHP student issue and tech issues, excuse me.
The only thing here, we do have a student that is currently in the program. A short while after she received her official acceptance letter, she reached out to me and requests to leave early. In August, she wants to leave at 11 o'clock because she's the maid of honor at her sister's wedding. I just need to know, that the attendance rule is very strict, and I need to know the board's opinion on how you would like for me to handle this. I did tell her that I could not give her an answer. I could not make the decision for her, that's at the discretion of the board, and I would let her know when you all discussed and determined what to do.
Haven't we had this come up in the past?
Yes,
ma'am. We have.
How did we handle it in the past?
We didn't allow it because time is so short, and it wasn't an emergency. We will handle emergencies on case by case, but this is if we do this for one, it's going to just be a domino effect and we can't allow them to be missing class like that.
I think we should just stick with what we've done in the past because, you know.
Okay.
So what will she be missing if she leaves at 11? She'll miss an hour or 2 hours?
No, sir, she'll miss, 5 or 6 hours. Yeah, oh, yes, sir, because, lectures are, unless it's exam day, lectures are scheduled from 8 to 5 every day. Because it is an accelerated program, so, we're limited to the time we have for lectures.
Mr. President, do we need to vote on this or not?
I think we have voted in the past, but I don't know if it's necessary.
Well, it's the consensus of the board that we continue what we said to do in the past, is that we adhere to the schedule.
Okay,
Is that correct?
That's good with me.
All right.
The only other question I have, I just want to, I think you all are aware that David from RJ Young will be there on Wednesday, as will many staff members, faculty, staff members here as well. We're going to give a mock quiz as we always do every year in July anyway, to try to diagnose and head off any device issues and or Wi-Fi issues. So all that's going to take place at orientation on Wednesday. If it's determined there are device issues that do not meet the specifications, although that has been out there for months, it's in the handbook, it's on our website. I have personally sent it to every student that was accepted into the program. Your device must meet these minimal specifications for course participation, because we have a lockdown browser, Canvas, we have a lot of things pulling at that. If we determine it is a personal device issue and they don't take care of that, the first exam will be in August. How would you like for us to handle that? If it's a personal device issue that does not meet the specifications to handle all of those things necessary to take exams.
Well, they wouldn't be able to participate, would they? If their device doesn't work, they can't take your exams and they can't.
That is true.
They're either in or out.
But it may not be up to specifications and pulling on the Wi-Fi that is
Right.
and it should, but
Right.
to your point.
If it's not what is required, would you let them, if they didn't buy their hygiene instruments, would you let them stay? No. This is part of the requirement. I think it
Right.
needs to be
Okay.
what is written in their materials.
Thank you. We're just trying to proactively head off any issues that would come up, at the last minute. So, okay, perfect. Thank you.
All right. Between sessions approval of research.
This is when I had to call you about ethics. I think we just need to get it approved.
Okay. I approved, was it 2 hours, Ms. Perry? 3 hours. I approved 3 hours for the board members to prepare for ethics presentation, since that we hadn't approved for that. And I just need to have that ratified by the board. Do I hear a motion to ratify that? Dr. Piszczek and Dr. White seconds. McElwain, yes.
White, yes.
Bishop, yes.
Talbot, yes. Perry, yes.
Okay. And that retroactively authorizes that according to the protocol we passed. All right. Budget, staff performance raise issues and budget calculations. Ms. White, Dr. White?
Yes, we're still working on it. I've got to do a little research. We should have everything. Dr. Finn and I will work together along with our executive director and have some information in the August meeting. Is that what we?
No, we're doing the percentage so that we can put the figures together for August.
Yeah. Dr. McElwain, you and I spoke about it. I think we still need a little, I get it. I still have to do a little research. I don't know if I can maybe send it to you, but you need the board to vote on it.
Well, I mean, can we give a range?
Yeah.
And let us work those numbers?
Okay. So, we talked about the range between 3 to 5%. And if everyone is good with that, what we're talking about is the, salary increase. And it would be a 3 to 5% increase.
I thought we talked about 2 to 4.
2 to
We talked
4.
3 to 5 or 2 to 4?
I've had several.
I talk about so much
meetings.
stuff. I have to.
I
Okay,
think you said 2 to 4 yesterday. And
okay,
you were proposing,
yeah.
yeah, just trying to figure out where.
Let's do that. Let's do 2 to 4. And we'll work from there.
Okay.
And then we'll hone it down to something definite, and that'll give us the ability to do some budgeting and look at it. Okay? Or
I make a motion that we have the range of 2 to 4% for budget purposes.
I'll second.
Okay. McElwain, yes.
White, yes.
Bishop, yes.
Talbot, yes.
Harry, yes.
Okay. Dr. Finn, CE course approval. There was a human trafficking time 2, a malpractice CE.
Yes, sir. We've got 4 that have applied for it. Quality of Life Services, Third Millennium Classrooms, Singing River, Dentistry, and Baldwin County Dental Study Club. All of them provided the appropriate information.
Okay. I'll make a motion that we accept those. Second.
I second.
McElwain, yes.
White, yes.
Bishop, yes.
Talbot, yes.
Harry, yes.
All righty. Let's see, Dr. Matthews, requested to be able to do online after an accident that has immobilized him. And I think it will be appropriate to allow him to do all online as a compassionate thing. I'll make that motion.
I'll second.
All in favor?
Bishop, yes.
White, yes.
McElwain, yes.
Talbot, yes.
Harry, yes.
Okay. Dental license applications by credentials.
I recommend following for licensure by credentials after the passing of the jurisprudence.
Okay. We have a motion to accept the list of by credentials.
I second it.
And all in favor? McElwain,
Bishop,
yes.
White, yes.
Talbot,
Piszczek,
yes. Talbot, yes.
Talbot, yes. Okay. Now we have regional examination.
I recommend following for credentialing for licensure by regional exam after passing.
All right. I'll make that motion.
I second it.
Second by Dr. Piszczek. All in favor? McElwain, yes.
White, yes.
Bishop, yes.
Talbot, yes.
All right. Now we are down to dental hygiene license applications by regional examination.
I make a motion that the following be licensed by regional exam following the jurisprudence.
All right. We have a motion on the floor. A second, please.
Second.
All in favor?
White,
McElwain,
yes.
yes.
White, yes.
Bishop, yes.
Talbot, yes.
Okay. Retired disabled license is for the list. I make that motion.
I second it.
Second by Dr. Piszczek. All in favor? McElwain, yes.
White, yes.
Bishop, yes.
Talbot, yes.
All righty. We're down to military spouse portability. There are 2. I make that motion.
I second it.
Piszczek seconds. McElwain, yes.
White, yes.
Bishop, yes.
Talbot, yes.
All right. We have done our enforcement previously. And do we have any investigations?
He did not have anything for this.
Doctor, okay, Mr. Youngblood didn't have anything. All right. Are there any more matters that need to come before the board?
Research approvals.
Oh, that's right. You're right. Okay, y'all.
The only other thing that we need to do is the board manual. I'd like to add that to the agenda next month, so we have some time to just kind of go over some highlights. And hopefully everybody,
Well, we've sent that out, correct?
we have not.
We have not. Well, we need to send it out, and let each person have a couple of hours to review it before next month.
Okay.
That way we can really talk about it.
Okay.
So I approve 2 hours for review of board manual.
How many hours for Dr. Watt?
Oh, he did that in, let me see,
Yeah, we
in
have to-
June.
To do it each month.
Oh, wow.
Yeah,
Okay.
because, I mean, it may not need it every.
Okay, I think I gave you 3 hours before.
Yes.
So Dr. White has 3 hours on it, and then each board member gets 2 hours to review it.
Do you need to make a motion on that?
Let's go through all of them.
Talbot and I are still working on this online ADHP.
Okay, and how many hours do you request?
Yeah, 2 is good.
2 hours. All right. I continue to work on anesthesia education and possible OB, possible course requirements for safety. And I like 2 hours for that. It's an ongoing thing because it takes a long time to look through all this research.
Are we putting DPA in here or we're leaving DPA out?
I made 2 hours for DPA.
Okay, well, let's put 2 hours for DPA research for everybody. All
And
right,
I don't need hours for this, but I'm just gonna let you all know I'm gonna research Botox.
Okay.
I don't need time for it.
okay,
I'm good with it. I just think that I need to satisfy the hygienist as to why we are not doing
okay.
any further, so I'm gonna work on that.
All right. Are there any other items of review? You know that during the month, if you have something come up that requires excess time, to contact me or Dr. White, and we can give approval, and then that has to come back to the next meeting. Okay? I make a motion that we approve of the request for research hours as presented. Do I hear a second?
Second.
Second by Dr. White. All in favor? My yes.
White, yes.
He said yes.
Talbot, yes.
Yes.
All right. That passes. Do I hear a motion that we adjourn? Motion by Dr. Talbot, second by Dr. Piszczek. All in favor? McElwain, yes.
White, yes.
He said yes.
Talbot, yes.
Period.
All right, thank you.
Wait, I'm sorry.
What?
Oh, I forgot. So, never mind. I don't need to do the
What is
research anymore. Well, the research for the salaries, but I don't need to do that anymore. We kind of wrote it already.
Okay.
Yeah.
All righty.
Yeah. I have juicy Lacey. I don't see it. Do I need to walk up there real quick?
What do you mean?
She's supposed to have juicy Lacey Should I walk up there?
Yes,
Hey,
please.
don't leave.
I won't.
I'm gonna walk up the stairs. Y'all know how I love walking up.